"Excuse me, you can't do that." The sharp voice of Nurse Sandra Mitchell cut through the ICU like a scalpel as she stepped between the young black doctor and his patient's bedside. "I don't know who you think you are, but only attending physicians can adjust these medications." Marcus Williams looked up from the chart he was updating, genuinely surprised to find the 15-year veteran nurse blocking his path with crossed arms and an expression of absolute authority. But what Sandra didn't know was that she had just challenged the chief of surgery, and her career was about to change forever. Mercy General Hospital's intensive care unit represented the pinnacle of critical care medicine in Atlanta, a place where life-and-death decisions were made every hour and only the most skilled medical professionals were trusted to work. The 40-bed unit hummed with controlled urgency, filled with the steady beeping of monitors, the whispered conversations of medical staff, and the quiet determination of people fighting to save lives. Located on the hospital's 7th floor, the ICU served the most critical patients in the region, from trauma victims to post-surgical cases requiring round-the-clock monitoring. Marcus Williams had arrived at Mercy General at 6 a.m. for what he expected to be a routine morning round, checking on the post-operative patients from yesterday's complex surgical procedures. At 28, he was the youngest chief of surgery in the hospital's 150-year history, a position he'd earned through exceptional skill, innovative techniques, and a work ethic that had impressed even the most senior physicians on staff. His journey to this role had been anything but typical. Harvard Medical School, surgical residency at Johns Hopkins, fellowship in cardiothoracic surgery at Mayo Clinic, and board certifications that put him among the elite surgeons in the country. But Marcus understood that his youth and race made some people question his credentials, despite his Harvard diploma hanging in his office and the successful outcomes that had built his reputation. He'd learned to navigate these challenges with patience and professionalism, proving himself repeatedly, while maintaining the composure that excellent patient care required. This Thursday morning was particularly busy in the ICU. 3 patients were recovering from major surgeries Marcus had performed the previous day: a complex cardiac procedure, a liver resection, and an emergency trauma surgery that had lasted 8 hours. Each case required careful monitoring, precise medication adjustments, and the kind of detailed attention that could mean the difference between recovery and complication. Nurse Sandra Mitchell had worked in the ICU for 15 years, beginning her career when the medical field operated with stricter hierarchies and clearer boundaries between different roles. At 43, she took pride in her experience and knowledge, seeing herself as a guardian of proper protocol who ensured that inexperienced doctors didn't make mistakes that could harm patients. She'd trained dozens of residents and medical students over the years, teaching them the importance of following established procedures and respecting the chain of command that kept the ICU functioning safely. When Sandra arrived for her 7 a.m. shift, she began her usual routine of reviewing patient charts, checking medication schedules, and ensuring that all equipment was functioning properly. The ICU operated on precise timing and careful coordination between nurses, doctors, respiratory therapists, and other specialists who each played crucial roles in patient care. As Sandra moved through her assigned patients, she noticed a young doctor she didn't recognize working at the bedside of Mr. Patterson, a 65-year-old cardiac surgery patient who was recovering from a complex procedure. The doctor appeared to be adjusting medication dosages and updating treatment protocols, actions that required attending physician authorization according to hospital policy. Sandra's experience told her that this was likely a new resident who didn't understand proper procedures, possibly making changes that could compromise patient safety. She'd seen this before: eager young doctors who exceeded their authority, thinking they knew better than established protocols. Her job was to prevent these mistakes before they could harm patients. "Excuse me," Sandra said as she approached the bedside, her voice carrying the authority of someone accustomed to correcting medical students and residents. "You can't do that." Dr. Marcus Williams looked up from Miss Peterson's chart, genuinely confused by the interruption. He'd been adjusting the patient's cardiac medication based on the latest lab results, a routine decision that fell well within his responsibilities as the surgeon who had performed the procedure. "I'm sorry," Marcus replied politely, though he could feel the eyes of other staff members beginning to focus on the interaction. "I don't know who you think you are," Sandra continued, her voice growing louder as she became more confident in her assessment of the situation, "but only attending physicians can adjust these medications. You need to step away from this patient and get proper authorization before making any changes." Marcus felt a familiar mixture of frustration and disappointment wash over him. This wasn't the first time his authority had been questioned based on his appearance, and it probably wouldn't be the last. But in the ICU, where patient care was paramount, he knew he needed to handle the situation professionally while ensuring that his patient received appropriate treatment. "Nurse Mitchell," Marcus said, reading her name tag, "I understand your concern for proper protocol, but I am the attending physician on this case. I performed Mr. Patterson's surgery yesterday, and I'm adjusting his medications based on his current condition and lab results." Sandra's expression didn't change. In her experience, residents and medical students often claimed more authority than they actually possessed, and this young man's confident manner seemed inappropriate for someone she assumed was early in his training. "I've been working in this ICU for 15 years, Sandra replied, "and I've never seen you before. Hospital policy requires that medication changes be made by authorized attending physicians, and I need to see proper identification and verification before I can allow you to continue." The confrontation was beginning to draw attention from other staff members. Dr. Jennifer Adams, a senior ICU attending physician, paused her own patient rounds to observe the situation. Respiratory therapist Mike Rodriguez stopped his equipment check to listen. Even some of the patients' families in nearby rooms were beginning to notice the raised voices. Marcus realized that this situation required immediate resolution, both for the sake of his patient's care and for the professional atmosphere of the. He reached into his white coat and pulled out his hospital identification badge, which clearly displayed his name, photo, and title, Dr. Marcus Williams, Chief of Surgery. "Here's my identification," Marcus said calmly, handing Sandra the badge. "As I mentioned, I'm Williams, Chief of Surgery. Mr. Patterson is my patient, and I'm providing the post-operative care that his condition requires." Sandra examined the badge, her confidence beginning to waver as she processed what she was seeing. The identification was clearly authentic, bearing all the proper hospital seals and security features, but she struggled to reconcile the young man standing before her with her mental image of what a chief of surgery should look like. This says you're the chief of surgery," Sandra said, her voice losing some of its authority as doubt crept in. "That's correct," Marcus replied patiently. "I've been chief of surgery here for 18 months. I performed Mr. Patterson's cardiac procedure yesterday, along with the liver resection in bed 12 and the trauma surgery in bed 18. All 3 patients are under my direct care." Dr. Jennifer Adams approached the group, recognizing that the situation required senior intervention. She'd worked with Marcus for over a year and had nothing but respect for his surgical skills and patient care. "Is there a problem here?" Dr. Adams asked, though she'd overheard enough of the conversation to understand the basic issue. "Adams," Sandra said, clearly flustered, "this person claims to be the chief of surgery, but I've never seen him before, and he looks too young to hold that position. I was trying to ensure that proper protocols were being followed." Adams looked between Sandra and Marcus, understanding immediately what had occurred. "Nurse Mitchell, this is indeed Dr. Marcus Williams, our chief of surgery. He's one of the most skilled surgeons I've ever worked with, and these patients are absolutely under his care." Sandra felt her face flush with embarrassment as the reality of her mistake became clear. She'd challenged the hospital's chief of surgery, questioning his authority and competence based on assumptions about his age and appearance. "Dr. Williams," Sandra said quietly, I apologize. I didn't realize." Marcus could see the genuine distress in Sandra's expression, and despite his frustration with the situation, he recognized an opportunity for education rather than punishment. The ICU was a high-stress environment where clear communication and mutual respect were essential for patient safety. "Nurse Mitchell," Marcus said, his voice remaining calm and professional, I understand that you were trying to protect your patient and ensure proper protocols were followed. That's commendable, and it's exactly the kind of vigilance we need in the ICU. He paused, choosing his words carefully. However, I think this situation highlights the importance of verifying information before making assumptions. In the future, if you have questions about a physician's credentials or authority, I'd encourage you to check with nursing supervision or simply ask to see identification rather than making public challenges that could compromise patient care. Sandra nodded, though she was still processing the magnitude of her error. Dr. Williams, I'm truly sorry. I hadn't seen you before, and I made an assumption that was clearly wrong. The ICU can be overwhelming, Marcus replied, and with rotating staff and different shift schedules, it's not uncommon for team members to encounter colleagues they haven't met before. What's important is that we learn from this experience and use it to improve our communication and teamwork. Dr. Adams observed the interaction with approval, impressed by Marcus's handling of what could have become a much more difficult situation. His response demonstrated the leadership qualities that had made him successful as chief of surgery, the ability to educate rather than humiliate, to focus on solutions rather than blame. Dr. Williams, Adams said, would you like me to introduce you to the nursing staff who might not have had the opportunity to meet you during shift changes? That's an excellent idea, Marcus replied. I think it would be beneficial for all of us to have better communication and recognition among team members. Over the next few minutes, Dr. Adams introduced Marcus to several nurses and support staff members who worked different shifts or had recently joined the ICU team. The introductions were professional and cordial, helping to establish the personal connections that made healthcare teams function effectively. Sandra observed these interactions, beginning to understand that her error hadn't just been about one doctor. It represented a broader failure to recognize and respect the diverse leadership within the hospital. She'd made assumptions based on age and race that had no bearing on medical competence or professional authority. As the morning progressed, Marcus completed his patient rounds while Sandra continued her nursing duties. The immediate crisis had passed, but both understood that the incident would have lasting implications for their professional relationship and the broader ICU culture. During her lunch break, Sandra sought out Marcus's office on the 5th floor. She'd spent the morning thinking about their encounter and realized that a more private conversation might help address the underlying issues that had led to her mistake. Williams, Sandra said when Marcus answered her knock, I was wondering if I could speak with you privately about this morning's incident. Marcus invited her in, gesturing to one of the chairs across from his desk. His office was modest but professional, with medical journals, patient charts, and surgical references filling the bookshelves. His Harvard diploma and board certifications hung on the wall along with photos from medical conferences and surgical procedures. I wanted to apologize again, Sandra began, but I also wanted to understand how I can do better in the future. I pride myself on being a professional nurse who puts patient care first, and I'm troubled by what happened this morning. Marcus appreciated her willingness to engage in this difficult conversation. Sandra, I can call you Sandra, right? I think your intentions were good. You wanted to ensure that patients were receiving appropriate care from qualified physicians. That's exactly what we want from our nursing staff. But I made assumptions, Sandra interrupted. I saw a young black doctor and immediately assumed he couldn't be in a position of authority. That's not who I want to be, and it's not the kind of nurse I want to be. Marcus nodded thoughtfully. The reality is that healthcare is changing. We have more diverse leadership, younger specialists who've completed accelerated programs, and different approaches to medical training. Some of these changes can be surprising if we're not prepared for them. How do you handle these situations? Sandra asked. I imagine this isn't the first time someone has questioned your authority. Marcus was quiet for a moment, considering how much to share about his experiences. Unfortunately, you're right that this happens periodically. I've learned that most of the time, people aren't intentionally discriminatory. They're working from assumptions and expectations that may not reflect current reality. He continued. What helps is focusing on patient care rather than personal reaction. When someone questions my authority, I try to provide information calmly and then redirect the conversation toward what's best for our patients. Sandra listened intently, beginning to understand the additional challenges that Marcus faced in his role. Is there anything specific that I can do to support you and other physicians who might face similar situations? Actually, yes, Marcus replied. The most helpful thing is for experienced staff members like you to help educate newer team members about the diverse leadership in our hospital. When you introduce new nurses or students to the ICU, you could mention the different departments' heads, their backgrounds, and their expertise. I can definitely do that, Sandra said. Are there other ways I can help improve our team dynamics? Marcus thought about the broader implications of their conversation. I think having more informal opportunities for staff members from different shifts and departments to meet each other would be helpful. Sometimes these misunderstandings happen simply because people don't know each other personally. They discussed several ideas for improving communication and recognition among staff members, including brief team meetings, updated photo directories, and more structured introductions for new personnel. As their conversation concluded, Sandra felt that she'd gained valuable insight into both her own assumptions and the challenges faced by colleagues she hadn't previously considered. Dr. Williams, thank you for taking the time to discuss this with me. I promise that I'll do better in the future, and I'll work to help create a more inclusive environment for everyone. Marcus stood to shake her hand. I appreciate your willingness to have this conversation, Sandra. It takes courage to examine our own assumptions and commit to change. The incident between Dr. Marcus Williams and nurse Sandra Mitchell became a catalyst for broader changes within Mercy General's ICU culture. Adams, impressed by how both individuals had handled the situation, proposed a series of initiatives designed to improve communication and recognition among staff members from different backgrounds and experience levels. The hospital implemented monthly team meetings where department heads could introduce themselves to staff members from other shifts, creating opportunities for personal connections that prevented future misunderstandings. They also updated the ICU's orientation program to include more comprehensive information about the hospital's diverse leadership and the various pathways that brought physicians to their current role. Sandra became an advocate for inclusive practices within the nursing staff, using her experience with Marcus as a teaching tool for younger nurses who might make similar assumptions. She helped develop scenarios for training programs that addressed unconscious bias and appropriate ways to verify credentials when questions arose. Marcus continued to excel in his role as chief of surgery, but the incident reinforced his commitment to mentoring young physicians from diverse backgrounds who might face similar challenges. He began participating in medical school recruitment programs and professional development initiatives designed to support underrepresented physicians in leadership roles. 6 months after their initial confrontation, Sandra and Marcus had developed a strong professional relationship based on mutual respect and shared commitment to excellent patient care. Their collaboration became a model for how difficult situations could be transformed into opportunities for growth and improved teamwork. The ICU at Mercy General continued to provide exceptional critical care, but with a renewed emphasis on recognizing and respecting the diverse talents and backgrounds of all team members. The lesson learned from one morning's misunderstanding had created lasting positive changes that benefited both staff and patients. For Marcus Williams, the incident served as a reminder that breaking barriers in medicine required not just exceptional skill and knowledge, but also the patience and wisdom to educate others while maintaining the focus on patient care that had brought him to his leadership position in the first place. 2 years later, the Williams Protocol, the confrontation that had begun with a nurse questioning a doctor's authority, had evolved into something far more significant than either Marcus or Sandra could have imagined. The Williams Protocol, named in honor of the chief of surgery, whose grace under pressure had transformed a potentially divisive incident into a learning opportunity, had become the gold standard for addressing bias and improving communication in healthcare settings across the region. Mercy General's success in creating a more inclusive ICU environment had attracted attention from other hospitals facing similar challenges with diverse leadership and generational changes in medical practice. The hospital's training programs were being replicated at medical centers throughout the Southeast, and both Marcus and Sandra had become sought-after speakers at nursing and medical conferences. Sandra, now serving as the ICU's diversity and inclusion coordinator in addition to her nursing duties, often shared the story of her encounter with Marcus as a powerful example of how unconscious bias could affect even the most well-intentioned healthcare professional. Her willingness to acknowledge her mistake and commit to change had made her an effective advocate for examining assumptions and improving team dynamics. The incident had also led to Marcus being appointed to the hospital's board of directors, making him the youngest board member in Mercy General's history. His leadership in transforming a challenging situation into positive organizational change had demonstrated the kind of vision and judgment that the hospital needed as it navigated an increasingly diverse healthcare landscape. Patient outcomes in the ICU had improved measurably since the implementation of the Williams Protocol, with better communication and reduced conflicts contributing to more efficient care delivery. The protocol had proven that addressing bias wasn't just morally right, it was medically beneficial, creating environments where all healthcare professionals could perform at their highest level.